The Open Door. Jim Hannick here with fellow panelists Mario Ramos-Reyes and Christopher Zender. Today we discuss brain death and the determination of actual death. The topic brings us to the heart of what it is to respect the dignity of the human being. It is particularly timely since the Uniform Law Commission is currently studying the possibility of revising the 40-year-old Uniform Determination of Death Act. That's the Uniform Determination of Death Act, UDDA. Our special guest is Alan Shewmon, MD. He is Professor Emeritus of Neurology and Pediatrics at the Geffen School of Medicine at UCLA. Recently, he authored a statement on how not to revise the Universal Determination of Death Act, although revision is in order. Let's begin, as we always do, in prayer. Come, Holy Spirit, fill the hearts of your faithful, and enkindle in them the fire of your love. Send forth your Spirit, and they shall be created, and you shall renew the face of the earth. O God, who has taught the hearts of the faithful by the light of the Holy Spirit, grant that by the gift of the same Spirit, we may be always truly wise and ever rejoice in his consolation. Through Christ our Lord. Amen. I'm going to begin in a way at the beginning. Just what is the universal, I need to begin at the beginning. Just what is the Uniform Determination of Death Act? And let me add to that. What exactly is the Uniform Law Commission?
Okay, well, I'm no expert in legal matters, so I would defer to somebody who's more expert about what is the Uniform Law Commission. But the Uniform Determination of Death Act was proposed in 1981 by the Uniform Law Commission. And the reason that it came about is that for about 13 years up till then, there had been chaos in the legal statutory definition of death across the country. So in 1968, the Harvard Committee on Brain Death revolutionized this whole field by proposing a new definition of death, which was the complete cessation of all, not only brain activity, but in their opinion, spinal cord activity as well. And that coincided with the groundbreaking first heart transplant by Christian Barnard. So there was this meeting of circumstances, confluence of circumstances around that time that made everyone very interested in redefining the statutory definition of death so that especially so that vital organs could be transplanted without the surgeons being held legally liable for killing the patient. So the first state to change its statutory definition of death was Kansas in 1971. And there was a kind of domino effect after that, where a number of states redefined their statutory definitions along some neurological criterion. So the problem was, getting up to 1981, the problem was that every state was doing it differently. And so you could be dead in one state and alive in another state. And this was not a very good state of affairs across the country. So the Uniform Law Commission and the President's Commission, which was a multidisciplinary group consisting of doctors and philosophers and ethicists and lawyers, appointed by the president at that time, studied this whole topic of the definition of death and the criteria for it and the optimal legal statute for it. And so they came out with what is known as the Uniform Determination of Death Act, which was not a federal law, but it was a template with the hopes that states, the remaining states anyway, would use that template to draft their own state statutory laws about death. And that's exactly what happened. So in pretty short order after that, all the rest of the states revised their statutory definitions of death along the lines of the Uniform Determination of Death Act. So that's the history of it in a nutshell. That act and the corresponding state statutes has two branches. It says that if either there's irreversible cessation of circulatory and respiratory functions, or irreversible cessation of all functions of the entire brain, then the person is dead. So that's the essence of the Uniform Determination of Death Act.
Let me back up just a little bit. On this Uniform Law Commission, is the idea that that's the source of a template, that's a recommendation?
Right.
Aha, okay. So we have the Uniform Determination of Death Act, and it's not as if it's something from the legislature. It's something proposed by a Uniform Law Commission.
Correct.
Correct.
Yeah, it's not a law. It's a suggestion for law.
Right. Okay. Now you mentioned Kansas. People try to avoid mentioning Kansas, but Mario is from Kansas. So in honor of the Kansas reference, I'm going to ask Mario to push our discussion along. We've got a little bit of the framework in place.
Okay. Thank you, Doctor. I have a couple of questions. You mentioned that there was a need to make uniform the definition of death. What was let's put it this way, if a state have a different definition of death, what would be the consequences of that?
Well, I mentioned that already. A patient could be alive in one state and dead in another state, which doesn't make a whole lot of sense. That's actually the case now with states. Actually, there's just one state that has a religious exemption from the neurological criterion, and that's New Jersey. That's exactly why Geffen math was taken from California to New Jersey, because in California, she already had a death certificate, And in New Jersey, she was treated as a living patient. So it makes a big difference. And it's not a viable situation long-term across the country.
Okay. And is the is the brain the master integrator of the body, from which it would follow that when the brain stops functioning, the body dies? That is disintegrates.
That was the thinking at the time of the President's Commission back in 1981. So it was felt that as you say, the brain is the master integrator of the body, so that even if some cells or organs might remain viable, the body as a whole is no longer an organism. So it has died. That was the thinking at the time. The basis for that thinking was that patients who had devastating brain injuries and no brain function could not be supported for more than a few days. And they took that as evidence that these were just disintegrating corpses, essentially, that were temporarily maintained because of the life support. And people don't like to call it life support in that context because they feel that the patient isn't alive, so they call it organ support. But that was the thinking then. Subsequently, it became clear that this was a false premise, because as intensive care improved, more and more of these patients could be sustained for a long time. And by 1998, when I published a paper on this, I collected over 175 cases of brain death diagnosis where the patient survived more than a week. And some of those survived for months, and the record survived for 20 and a half years in that condition. Now, that may not be a desirable condition to be kept going in, but the point is these were not disintegrating corpses. They were living, severely disabled human beings. And so the premise that was behind the Uniform Determination of Death Act in 1981 turned out to be false. So people since then have been debating if there might be other rationales for salvaging the neurological criterion of death, besides this organism as a whole rationale. And the main contenders for that are that death is the irreversible loss of consciousness. And it doesn't matter whether the organism is living or not. So this is kind of psychological rationale or personhood rationale. And that is a radical redefinition of human life. If that were the case, then any permanently unconscious person would be considered legally dead. Therefore, the concept of a permanent coma would be even an oxymoron. So that affects many, many more patients than so-called brain death currently affects. And I don't think society is ready to go that route. Another contender is the combination of irreversible loss of consciousness and irreversible loss of breathing. And this is essentially the UK concept of death. And a third one was proposed by the US President's Council on Bioethics in 2008. And it's what's called the vital work rationale. The President's Council accepted the critique that at least some brain dead patients are living human organisms. But they still defended the concept of brain death by a novel rationale, which was that what is critical or essential to human life is what they call the commerce with the environment, the goal-driven exchange with the environment of oxygen, of nutrients, and so on. And they felt that anybody permanently without consciousness and without breathing lacked this goal-driven exchange with the environment and therefore was dead. So the debate continues, and as Jim mentioned, the Uniform Law Commission is now in the process of considering whether to revise the 1981 recommendations. And they will be considering these alternative rationales.
Christopher, it looks like we have consistencies and inconsistencies. Maybe some consistent motivations and some inconsistent testing. I don't know if you want to pursue that angle or you want to dig some more where we've been.
Well, I'm curious. I think we on the show here probably have some sense of what the whole parameters of this discussion are. What would our guest, what would the rest of us say is the alternative, or what are we proposing, or proposing anything as a determination of what constitutes human life in this case? What are the criteria that are being proposed here in contradiction and contrast with the what we've been talking
about? Well, I've proposed for many years now that it would be helpful to distinguish two senses of the concept death. And I really think that a lot of the impasse in these debates over the decades is due to people using the same word for two different concepts. And our English language, unfortunately, gives us just that one word, death. Other languages have more than one word for that, and they can discuss these differences in a more nuanced fashion than we can in English. But let's back up and note that even before the advent of ICUs and ventilators, when doctors declared death in a hospital setting, or maybe they were in the patient's home if they paid a home visit and the patient died, the doctor would put the time of death to be the time when circulation and breathing stopped, permanently stopped. Now, nobody had a problem with that timing of the moment of death. But if you were to talk to a theologian or a philosopher and said, when is the moment of death? Well, that would be when the soul leaves the body. And the timing of that is unknown. We can tell that the soul has left the body if there are such signs as rigor mortis or livor mortis and so on. But nobody can say exactly when that metaphysical moment occurs. Nobody had a problem with the fact that death certificates had a time of death that did not correspond to metaphysical death. So, and I think that's a very useful distinction, because society has to have some clear criterion whether someone is a member of it or not. So when someone dies, their spouse becomes a widow or a widower. Life insurances kick in. If it's the president of the United States, the vice president becomes president. And people start grieving. Family members begin to grieve at that moment. So there are all sorts of consequences of the timing of what we could call civil death, if you will, which is not to be equated with metaphysical or ontological death, but is nevertheless an important and useful concept. So I have maintained that an optimal criterion for civil death is the permanent cessation of circulation of oxygenated blood. And we just don't have a good criterion for the moment of metaphysical or ontological death. All we can say is whether we can say for sure that it has happened if certain signs are present. And otherwise, we have to be agnostic about it. I think that answers your question.
Yeah, it does. And I think it's curious is that the definition you give for civil death is very clear. Why depart from that? Why depart from the older standard to a newer standard? What's behind that?
The newer standard meaning the neurological?
Brain death, yeah.
Uh-huh. Well, I would say the motivation for the past 50 years has been transplantation. So, yeah, I mean, if you wait until cessation of circulation of oxygenated blood, then a lot of vital organs are not going to be suitable for transplantation. But if you have a patient whose brain is destroyed, but whose heart is beating fine and all the other organs are working fine, then that's an ideal candidate for transplantation. So that's really the motivation. Now, the demise of the concept of brain death doesn't necessarily mean the demise of transplantation, because we have a precedent of transplantation from living donors. For example, blood, bone marrow, a single kidney, a lobe of a liver. These things can be donated from living donors with obviously with informed consent about the risks and so on. But that principle, I think, can also apply to patients whose heart has just stopped, and once it's clear that it's not going to start up again, then that principle could apply to using those organs, because extracting them is not going to change at all the physiological process of dying. So there's a whole field of transplantation based on non-heart beating donors. It's also called donation after circulatory death. And people argue whether this is really death or not. But I would say that that argument is based on conflating the two concepts of death. Of course, it's not metaphysical death, but if you define civil death in terms of permanent cessation of circulation of oxygenated blood, then those patients can be declared dead.
What are some cases, as you look back at your practice, what are some cases that have really helped shape your own thinking?
Well, these cases are not in my practice, but
Your consulting practice.
they're not in my consulting practice either.
Your research practice.
Research practice, yes. So, well, the most striking case, I mentioned this boy who survived 20 and a half years in the state of brain death. He became brain dead at age 4 from meningitis. And his mother didn't accept that he was dead. And this was also at a time before there were diagnostic criteria applicable to young children. So the doctors were reluctant to apply the President's Commission criteria or the Harvard criteria or any other criteria to this young boy. So he was supported in the ICU. And amazingly, eventually he was discharged home. And he stayed home on a mechanical ventilator and nursing support and tube feedings for 20 and a half years. When he died, finally, they did an autopsy and there was no brain tissue inside the head. So it was clearly not a matter of misdiagnosis. He really had no brain function because he had no brain. Yet his organism survived that long because it was an organism as a whole. So I think that, and there are other less dramatic but nevertheless impressive cases of prolonged survival in the state of brain death.
About the case of the young woman who was transferred to New Jersey.
Her case is remarkable for a different reason. So she, there was no question about the application of the diagnostic criteria for her. Some of these chronic cases have been questioned whether they were really correctly diagnosed. In Jahai McMath's case, she clearly fulfilled the diagnostic criteria, and even there was a court-appointed independent neurologist who came and repeated all the examinations a couple of weeks later and concurred that she did meet the diagnostic criteria of brain death. She had 4 EEGs, all of which were flat. And she had a blood flow test, which showed no blood flow to the brain. So by any standard, she was properly declared brain dead and was given a death certificate in California. In New Jersey, she developed menstrual periods. So she was 13 years old at the time and had not yet had her period. But while brain dead, or supposedly brain dead, she developed menstruation and had 3 menstrual periods altogether. So that's in itself quite remarkable, because here's a body that is supposed to be a corpse, yet is menstruating. She also went through puberty and developed the secondary sexual characteristics. And after several months of being in New Jersey, her family started to note, or to suspect, that she was aware of them and was able to follow simple commands sometimes. As time went on, they became more and more convinced of this. And since they knew that nobody would believe them, they made videos of testing sessions where they asked her to move her thumb or move her left arm or her right foot. And many times she would do that in the videos. I became very interested in her case after they began to report these phenomena that were really inconsistent with a diagnosis of brain death. And they entrusted to me over 50 videos. And I've done a statistical analysis of those videos. And there's no way that you can explain these movements as chance occurrences of random, spontaneous, involuntary movements that just happen to occur after commands. They're too specific to the body part, and they occur too soon after the command. So here is somebody who demonstrates that the diagnostic criteria that are used throughout the country are not foolproof. And so that's a whole different issue from the conceptual one, whether brain death is death. This case has to do with whether the diagnostic criteria that are currently standard adequately diagnose whether the brain is irreversibly non-functional. So I think Jahai's case and some others that have been published, one of them by myself, show that there are false positive diagnoses, even following the most rigorous accepted standards.
Mario, we've got conceptual problems, we've got clinical surprises. What thoughts do you have at this point?
Um, there is I reread the statement by John Paul II in 2000, and it seems to me, correct if I'm wrong, that he was making the distinction between what we may call metaphysical death and physical death. But yet he says that the death is the death of the person, is a single event. And that single event, yes, what is happening is that the soul separates from the body. And you cannot perceive, we cannot perceive that with our senses, but yet we do through biological signs, which follow the death, that single event. And then we decide which one of these criteria, whether the criteria you're describing or brain death were the one that certified death. Now, do you think then, if that is the case, the statement or the, I don't know, the criterion of irreversible cessation, all function of the entire brain should be revised, or the neurological criterion should be revised in favor of a circulatory respiratory criterion of that?
Well, there are several parts to your question.
Yes.
Going back to the address of Pope John Paul II in 2000, I don't believe that he was making a distinction between what I've been calling civil death and metaphysical death. He was talking about metaphysical death when the soul leaves the body, and he was very careful in his choice of words in that statement. He deferred to the scientific community to provide the physical signs for when death has occurred. And he said that there is a widespread consensus about a neurological criterion, and that this criterion does not seem to conflict with a sound Christian anthropology. And the word seem was his original word in his statement. So, of course, it did not seem that way to him because the information that was given to him was provided by the international scientific community through his consultants. And clearly there is a favoring of a neurological criterion on the part of the international community. But as I've explained, that the rationale behind that, in terms of cessation of the organism as a whole, is no longer a viable rationale. And the rationales that are now being proposed, if Pope John Paul II could look at those now and assess them, I think he would say that they do seem to conflict with the sound Christian anthropology, especially the consciousness-based notion. So people who supported the idea of brain death around 2000 were very pleased with this statement that he made. But it was a conditional statement. And the Holy Father certainly was interested in ongoing investigations into the scientific underpinnings of neurological concept of death. And in fact, he encouraged the Pontifical Academy of Sciences to hold a third working group to hear the other side of the argument regarding brain death. And that group convened in 2005. So there had been previous working groups in the late 1990s. And so clearly the fact that Pope John Paul wanted this to be further studied indicated that he considered the scientific aspects of it still open to discussion. And rightly so. And at that meeting, there were multiple presentations providing evidence that brain death or cessation of brain functions did not correspond to human death. Interestingly, the Pontifical Academy of Sciences, which very much favored the notion of brain death, did what it could to suppress that meeting and did not publish its proceedings, and essentially deleted its occurrence from its archives and its calendar, and had yet another meeting after that in 2006, where the consultants were sort of handpicked to support the notion of brain death, until Pope Benedict insisted that Robert Shewmon and myself also be on that working group. But it was a foregone conclusion that that working group would come out in favor of a neurological criterion of death. So when Pope Benedict addressed Transplant Society in, I think it was 2008, he did not endorse the concept of neurological criterion of death, but rather he said that he insisted that the donors of vital organs be cadavers, ex cadavere in Latin. And I think what he diplomatically did not say speaks louder than words in the context of this debate. So, the church magisterium certainly has not made any statement in favor of a neurological criterion of death, nor is it in its competence to do so. It is competent to declare what kind of concepts of death are consistent with Christian anthropology, but it lacks the competence to say what medical criteria correspond with that concept.
We want to trust science insofar as it's really science. And we want to trust scientists insofar as they're really practicing science. And we want to make decisions that are evidence-based insofar as they are based on the actual evidence. there are some distinctions to draw here, are there not?
Absolutely.
And you can trust mainstream media to report on all of these things as they actually are. You can trust science editors, say, in the New York Times, or maybe not.
Well, I certainly trust science, but I don't trust everyone who publishes a paper in a scientific journal.
Since some of them have to be retracted.
Yes, and many of them are motivated by philosophies that masquerade as science.
Could you tell us, and this is a sort of an aside, but I had thought to ask you this privately. Could you tell us a bit about Robert Shewmon? He's always been one of my philosophy heroes.
Well, he was a German philosopher, a personalist philosopher, who passed away a few years ago.
Sadly.
Sadly, yes.
Although at an advanced age.
At a very advanced age, absolutely. And he wrote many articles, mostly in German, but many important articles affirming the intrinsic value of human life at all stages.
Someone, not something.
Exactly. And just as he defended the human personhood of the embryo, likewise he did of patients with devastating neurological injuries, including total brain destruction. That these are irreversibly comatose patients, but they are nevertheless living human patients.
There's a distinction between the subject of the person, the substance that is a person, and consciousness.
Absolutely.
Something has to be conscious. It presupposes a suppositum.
That's right.
Christopher, join us, please.
Sure. It's interesting we're talking about the something, the someone, but isn't this really at the root of the problem? The problem is not so much what medical criteria you use, that's sort of the effect. The problem is that it seems that those who, at least many of the people who are proposing, the brain death criteria, they have a philosophical way of looking at what a human person is. And they look upon them as a material thing. So it sort of makes sense if you look at that way that, well, to be what we all value as human life is no longer possible for them. So at that point, why would you keep them alive? But if you hold that there's something more to man than just his material body, but that there's a principle within him, a spiritual principle, then the whole parameters of the discussion change, it seems. And isn't that what the problem ultimately is how do we define what this creature we call man is? Is he merely a very highly advanced animal, or is he something more than a highly advanced animal?
No, I think you've hit the nail on the head. That is the core of the debate. And people who focus on consciousness as the essence of what it is to be human have a very different worldview from what you and Jim and I endorse, namely that there's a substance, the person is a living substance and cannot be reduced to the functions. There may be some obstacle to the exercise of those functions, but that doesn't mean that the substance is no longer there. So you're right. Many people who propose the consciousness rationale are materialists who think that consciousness, first of all, is just a product of brain activity and does not involve any kind of immaterial intellectual soul. And as materialists, they reduce the human being to this set of functions. And if a key function is missing, then in their mind, there's no longer a human being. So that's a very different worldview from ours that accepts the notion of a substance. I'm sure you philosophers could explain this much better than I could.
I'm not so sure, but Mario, please, we're coming close.
Can we say then, according to what you are saying, that the problem of science is a philosophical problem?
Well, no, the problem of science, I mean, if science would stick to its proper domain, then that's not a philosophical problem. It's an
well, but you are saying that scientists will follow the way that they reason according to their view of the human person, and the view of the human person is a philosophical problem.
Right, but when they talk about that, they're talking not as scientists, but as armchair philosophers.
I understand that, but what I'm saying is that if I have a starting point, a theory how I know, and from that follows or flows my view of the human person, and based on that I do science, it seems to me, correct me if I'm wrong, that philosophy precedes science. Therefore, science is a philosophical problem.
I'm not quite sure whether we're agreeing or disagreeing about this.
Well, culture is a topic for philosophy, so also is science a topic for philosophy.
Sure, and there's philosophy of science, but I mean, when scientists do science, they're doing experiments and they have hypotheses and they test them in rigorous ways. I mean, that's doing science. And like anybody else, a scientist can have ideas about what is human nature and so on, but that's not doing science.
Are those ideas perhaps ineradicable? That you can't expect a scientist to actually do simple science without some kind of presupposition of what he's looking at. Yeah.
Well, yeah, of course, the scientist has a worldview behind everything because everybody has a worldview. But I don't think that would or should affect how he does proper science in his laboratory.
I have one last question for you. It's rather general. You've had a lot of support for the statement that you've authored, and it's come from some surprising sources. I saw the name Peter Singer. I saw that name right there. I was surprised. Are you pleased with the amount of support you've had? Did you anticipate that much? Are you surprised at some of the people who have supported your intervention?
Well, I'm very pleased, of course. I'm not entirely surprised because in my discussions with colleagues over the years, I know there are a lot of people who are not satisfied with the current UDDA for different reasons. And there are a lot of people who are concerned about the diagnostic accuracy of the brain death criteria of that are standard across the country. So I must say I wasn't surprised by the number of supporters of this statement, but I am pleased by the diversity of opinions that they represent, and I think it shows the strength of this whole effort, that there are supporters from quite a wide variety of opinions about human nature and death and ethics and so on.
So dialogue has proved effective.
Well, yeah, definitely.
That's good to know. Good to know. All right. On that positive note, we'll close with today's gospel, as we always do. And of course, thank you so much, Dr. Shewmon, for joining us.
You're welcome.
This is from Luke. At that time, John summoned 2 of his disciples and sent them to the Lord to ask, "Are you the one who is to come, or should we look for another?" When the men came to the Lord, they said, "John the Baptist has sent us to you to ask, are you the one who is to come, or should we look for another?" At that time, Jesus cured many of their diseases, sufferings, and evil spirits. He also granted sight to many who were blind. And Jesus said to them in reply, "Go and tell John what you have seen and heard. The blind regain their sight, the lame walk, lepers are cleansed, the deaf hear, the dead are raised, the poor have the good news proclaimed to them. And blessed is the one who takes no offense at me." Come, Lord Jesus, come. Thank you so much. Thank you,
Thank you.
Mario. Thank you, Christopher.
Thank you.